And then, although I mentioned that the focus of the talk is the methodology and the approach around understanding clinical trials at an individual level, I'm going to use the lens of a single study that we published in the European Heart Journal a couple of months ago that focuses on a specific application. So if you don't have the study and would want to follow along, if you point your camera to the QR code, you should be able to get the study on your phone. I'll give a second. And also gives me a chance to talk about the group. We had collaborators across the country. The first author in the study, Evangelos, is a rising cardiology fellow at Yale, and then a group of investigators who span expertise in biostatistics, in computational sciences, and clinical cardiology. So I was told in advance that the group that I'm presenting to is fairly diverse in their skill sets and their experience. So bear with me as I may actually oversimplify some of the clinical concepts for the methodological folks and some of the methodologic concepts for the clinical folks. So first off, why study this problem? So stable coronary disease is one of the leading causes of healthcare visits, as leads, and ischemic heart disease is one of the leading causes of death globally. And what is stable coronary disease? It is not a heart attack. It's not people coming to the hospital with their crushing chest pain. It's this gradual development of atherosclerosis, which is this gunk inside the coronary blood vessels that over time can cause narrowing of the lumen to the point that the myocardium is unable to get enough oxygen, especially during periods of stress. And stable coronary disease often comes in with chest pain as a key presentation. And chest pain is typically exertional, that somebody does not have discomfort at rest. When they exert themselves, they have reduced myocardial blood flow, or blood flow that does not compensate for the amount of metabolic demand, which leads to chest discomfort because of ischemia. So there are two distinct disease entities, aspects of the disease. One is the anatomical disease, which is that there is a severe fixed coronary stenosis, and that can be evaluated using something that injects iodinated contrast into the coronary, into the peripheral veins, and timed with the acquisition of a CT scan of the heart, so you can see what the anatomy of the coronary blood flow is, and see if there's any areas where there's a luminal either obstruction or irregularity of a larger degree. On the other hand, functional tests are designed to capture the symptomatic aspect of disease, where there is there's a stress placed on the heart muscle either through vasodilation or through exertion, and we try to maximize the push the diminished coronary vascular reserve so that the diseased vessel that is after the stenosis is unable to keep up with the oxygen requirements of the body, and you are able to diagnose that either through electrical abnormalities on an ECG, on a mechanical abnormality like a wall motion change, on an echocardiogram, or just a blood flow like a nuclear perfusion stress test. And these two modalities have been at the forefront of diagnostic cascades of coronary disease for a long time. However, even though we've known about them, we understand their test characteristics, the most recent guidelines, which come from the European Society of Cardiology in 2019, give an equal emphasis on both diagnostic testing strategies. So either you could do functional imaging, or as I said, stress testing, or coronary CTA for somebody with suspected stable coronary disease. And the guidelines also specifically give a very subjective sense of how you should choose patients between one versus the other. It allows clinicians to choose any test based on where they feel it'll be best performing. And then also they should choose a test based on local expertise and availability, which I think is a little hard to follow because they are very different tests. There's definitely a pathophysiologic difference between disease entities, which will be better picked up by CTA versus stress tests. And so the only thing that we have thus far to offer is this continuum of risk, that very low risk individuals benefit from a coronary CTA, and you find that they have less amount of calcium, so less artifacts, and are able to rule out disease well. On the other end of the spectrum, there are individuals who have high ischemic burden and are more likely to be able to be diagnosed by a stress test. But this is obviously very crude in terms of how we can apply it to clinical practice. And the landmark study that actually underlies all this discussion is the PROMISE trial. This is a NHLBI-funded multi-center study in the North America, US, and Canada, which included around 10,000 individuals and half and half randomized to CTA or functional testing, and followed for a median of around 2 years for a composite of all-cause mortality, non-fatal myocardial infarction, unstable angina hospitalization, and procedural complications, including renal dysfunction and angioedema. And the key observation from this study is that there is no significant difference between anatomical or functional testing. And this finding, even though the study was underpowered to detect a difference, has been the basis of the equivocal nature of the guidelines. So there's always a question that we did spend so many resources in conducting such a large, important study. We did a human experiment of sorts. And in the end, we were unable to take that into any form of method. Is there any question? Sorry.
I actually have a quick question about that last slide to understand what is meant by event. So this is following two cohorts of patients, one each received different sort of test, and you're measuring among those people how many of them died or went to the hospital or what part of this composite.
So it's a time to event outcome. So in a time of having any of these outcomes at first ever thing. So essentially both at obviously randomization proceeded over several years. And then everybody was nearly more than everybody was followed for a set period of time, but at least half were followed for 2 years. And then any of these outcomes being recorded in either arm were chosen as the outcome of interest. I think if I can sort of maybe latch onto that point a little more, I would say that this was a hard outcome-based trial focusing on large, clinically important outcomes. Although the testing strategy was just a strategy trial, it wasn't actually using a treatment cascade that you had. If you got anatomical testing, you had to do these things that would lead to an improvement in outcomes. The underlying assumption is that if you use the right test for the right patient, you would end up picking up the disease that was clinically important and then do therapeutic decisions and make therapeutic decisions that will lead to an eventual reduction in adverse events. Did I answer that question?
Yes, thank you.
So
and I would just say that was a pretty high bar that the investigators chose, because as Rohan's saying, like putting someone in the scanner is not going to save their life, not going to prevent a heart attack, not going to prevent them from dying. So it's really like, and then on top of that, many of the tests that are going to be done are normal. So it's like differential impact of abnormal tests, which then leads the doctor to do something good, which then can prevent a heart attack. So in some ways, like I applaud them because they actually went for the gold standard of outcomes. In other ways, they kind of were set up for failure because it's a really hard thing to show with the diagnostic strategy.
Absolutely. And I think, even with the outcome, I think they had powered for 8% absolute risk, and then 15 20% absolute relative risk reduction. And their event rates were about 3%. So there's definitely, they didn't even hit the required number of events, which is actually probably, during this entire course, ASCVD-based trials have often come out now, mostly from the effect that prevention is so strong that it's harder to differentiate between the two arms. So, I mean, that's definitely an important sort of consideration when interpreting any of these trials is how did they bring about a change downstream? Perfect. Thank you. And I think, so this sort of led us to sort of think about this problem a little more in a more general term. So how we interpret randomized clinical trials is we enroll patients, who randomize them to intervention and the control arms. Then we assess outcomes in the intervention and control arms. And when we assess differences in outcomes across two arms as average treatment differences. So whatever is the number, is differentially, is it higher or lower in the intervention versus control arm? But when the trial is null, especially it is true for trials that are positive, but more so if we're null, that it's not as if that nobody benefited from the intervention. It could be the case, but often we recognize that there are individuals that benefit from one study arm, and there are others who benefit from the control arm. So there is theoretically an outcome heterogeneity. It's just that among a sea of people who don't benefit, or it's hard to identify people who actually benefit from the drugs or the therapy that you tested in the trial. So current way, as Amit mentioned early on in the discussion, is that we focus on large patient subgroups. So these are subgroup analysis from the PROMISE trial that I just showed you, which use a fairly convoluted method of figuring out if individuals who, if gender, having women versus men benefited more from CT versus stress testing. There are a lot of considerations around, anatomical consideration, breast tissue artifact, how there'll be maybe false positive or negative tests. So one of the conclusions from the study here on the left was that stress test was less discriminatory in women versus men. So CT was a preferred test in women versus men. Similarly, patients who had diabetes, if they underwent stress test, the blue line on top, they had more events versus those who underwent CTA. People have obviously posited mechanistic explanations, but the key aspect for me in this study and for our entire group is that this is such a crude generalization. I mean, no two women are alike, no two patients with diabetes are alike. So this is a hard way to sort of study subgroups, even in a post hoc manner. And before I miss anything, I do want to mention a second trial that is important in this discussion and does come up in the end when we discuss validation of our tools, is the Scott Hart trial. So it actually does not, this is not a trial of anatomical versus functional testing, which the PROMISE trial tested. The Scott Hart instead focuses on using the anatomical testing as an adjunct to standard care. The study was wildly positive, generated a lot of attention about CT, probably even increased the adoption of CT in practice, though the biggest limitations are how the study was conducted using claims data to adjudicate outcomes. And then the other component is that, if you say something is better than standard care, the standard of care should be standardized. And there is just no standardization on clinical testing for chest pain. And that's something we'll go through a little bit towards the end when we discuss validation. And this is already mentioned that the CTA addition was associated with mass improvements in outcomes. So the key objectives of our study is first to evaluate heterogeneity in outcomes across the phenotypic spectrum and not be limited by major key subgroups. And then using this information from heterogeneity, personalize the selection of the optimal diagnostic test, or at least attempt to do so. So the PROMISE trial was the study population we chose to start with. This is an NHLBI funded trial, so this was available to us through the BioLink portal. And we can start this particular assessment of the population from the right. This is easier to see from the right. So half the population got anatomical, half got functional testing. Within functional testing, vast majority underwent stress nuclear test, which is the perfusion test, how much blood actually reaches the tissue during stress and vasodilation, versus echocardiogram and ECG. And this reflects, I would say, even current practice, where nuclear stress tests are the predominant stress test. And if you trace back in the half and half randomization, most of the individuals who underwent a CTA were not those who were going to undergo an ECG or an echo, but were people who were planned to undergo stress nuclear tests for the most part, highlighting that these individuals would have been equivalently been in the stress nuclear arm as well. And then finally, the distribution of men versus women was fairly consistent. If anything, females were overrepresented, which is kudos to the trial, given the challenges of recruiting in this space among women. So how do we go about going from having participant level data from—
Can we ask for questions, or should we wait to the end?
No, please. This is better to ask questions.
How did they figure out what the intended test was pre-randomization? I'm not familiar with that.
We just asked them essentially, hey, which test do you want to give them? So this was a pre-randomization questionnaire that what test do you intend to do with the patient? And they said, oh, I want to do a stress nuclear. They would just mark that down. And I only include this information not to confuse or distract, is the idea that a vast majority of people were intended to go on the stress nuclear arm, which was the true case in the stress arm, but reflected the population that underwent CTA for the most part.
Thanks.
So I think going from, so we had participant level data from the PROMISE trial, and going from there, having participant level data to understanding individual patient phenotypes was the key, theoretical and methodological jump for us. So we created a theoretical framework to understand this better. We felt that each patient in a PROMISE was living in this multidimensional universe where they were closer to some individuals in their characteristics and very distant from them in some other characteristics. And randomized trials are very key to understand that they're not like case control studies. So you don't have like a patient and a matched control, and you have like essentially by design an identical person as far as theoretically how case control should be done. What you really have is that you take some characteristics from patient A that match to a partial set of characteristics from patient B and partial set from patient C and so forth. So when you have assembled a full suit of the trial, The table 1 of the trial, which the clinicians in the room would follow, is matched on hypertension being equivalent in active and control arms, diabetes being equivalent, and so forth. So all characteristics are matched, but they're matched on average. And it's not the same person contributing on both sides, similar people contributing on both sides. So we felt that there would be heterogeneity among people, but there'll be some people who will match on some characteristics and some who won't. And so if we went for an example from our index patient 1 here for that reason, every person, if this person was in a multidimensional space, people closer to this person will be more similar, and the patients farther out will be most dissimilar to the individuals. So if you could conduct an experiment embedded within the randomization space of where we compare the effects on patient 1 and people around that patient for the different treatment arms, you would be able to infer a more personalized interpretation of the test for that individual. And the key aspect is we have to ensure why does randomized clinical trials lend to a unique advantage in this particular example is because if you take pre-randomization features, none of those features are actually guiding the use of the intervention. The intervention is randomized. So it is given without clinical bias, without an indication, without a reason to use that test in that particular individual or use that therapy in that individual, allowing you to see a more unbiased estimate for using the trial in similar individuals. So what we did for the PROMISE trial is we used the inclusion criteria for the PROMISE trial. We had only the PROMISE participants. We extracted their baseline clinical phenotype variables. And this included a set of 56 variables based on availability throughout the trial and spanned demographics, risk factors, presenting symptoms which were captured in questionnaires, structured elements from the electrocardiogram, which was done at rest. They're on their current medications, including antiplatelet agents, rate control agents, and clinical assessments, including ASCVD risk scores that suggest the likelihood of CAD and their chest pain presentation, like the Diamond Forrester score. And then using the theoretical framework that I just laid out before, we use something known as the Gowers distance metric. And the methodologists in the room would obviously follow this along, but Gowers distance measure is it's a measure for dissimilarity metrics for mixed type of data, where data are both continuous and categorical. You are able to create between pairwise, patient 1 and patient 2, across these 56 features. If they were identical, they would have a distance of 0. If they had no overlapping characteristics on the 56 features, they would have a distance of 1. So using this sort of approach, we created a Gower distance matrix for each of the individuals against every other person in the trial. And then we wanted to use some sort of interpretation of the trial data set. So we use visualization using UMAP, which is just a 2-dimensional projection of the multidimensional relationships of these individual patients. And then finally, I want to highlight that everything that we have done thus far is pre-randomization. So all the distance measure creation, all the creation of a phenomap doesn't actually interfere with the fact that the patients were subsequently randomized and were received therapy in an unbiased manner. And for each person, as for the primary analysis, we chose their 5-person immediate neighborhood. By that, I mean every individual was compared to 5% of the trial population that was resembled closely to them. For a 10,000 person trial, that's around 500 individuals around each person. And in this patient-centered phenotypic neighborhood, we constructed cost proportion hazard models to assess the individualized hazard ratio for the primary outcome of the PROMISE trial. And this was repeated for each participant in the PROMISE trial. Is this clear?
Yeah, I really like. I really enjoyed reading about this the phenomapping approach in the EHJ paper. I don't know that any of it we've used that a lot in our groups. Are there other examples, either in clinical medicine or outside of medicine, where folks have found this phenomapping and neighborhood approach useful?
I would say I would give 2 key examples. I would say pheno groups have been things that people have compared before, where folks have used something like a k-means cluster to create subgroups. I think I do feel that there's innovation here. Yale has submitted for protection, intellectual property protection for this work too, mostly for the idea that we haven't actually found a similar approach to treating trial populations. There are other ways to interpret trials, but I feel we actually haven't found a lot of examples of this.
Great.
That was a roundabout way of answering that. No, sorry.
Yeah, go ahead, second.
How was the 5% cutoff selected, and how sensitive are the hazard ratios to, I don't know, increasing it to like 10 or something?
That's a perfect. I mean, I do delve into it in a bit, and I think that's an excellent question. And actually, that is the key assumption as far as the individual hazard goes. But I kind of will highlight later how that was independent of the distance metric for the most part, if you chose within a certain range. But there are values to choosing a smaller distance versus a larger one. And I think I'll kind of get into it, and maybe we can discuss it more at that point.
Sure, thank you.
Also, just one last question. So does this mean that you have one curve for every patient, or am I missing something?
Yeah, so so essentially a patient-centered 500-person cohort study where there are 500 people like that patient. Some of them by design would receive intervention arm, and some of them by design would get the control arm. And then we essentially create a cost portion hazard for each patient centered cohort.
But does every patient in the data set form one result in one cohort? So
yes,
every patient will show up many times.
Every patient will be the center of their own universe and will be part of other people's universes. Yes.
Thank you. Thank you for clarifying.
So I think first off, I will just delve into the Phenomap. So this is the UMAP of the clinical trial population. This is based on those 56 pre-randomization features. So first, as a sanity check, on the left, you have the plot that assesses treatment allocation. So in this representation, we have mathematical, tools that bear this out numerically, but you can see visually that the functional and the anatomical arms are uniformly distributed throughout the phenotypic space. So there is no bucket which has preponderance of the functional or the control arm. If you take a large enough bucket, if you take a very small center, obviously there's likelihood of being getting one arm versus the other. But for the most part, if you take large enough chunks of the trial, you'll have a uniform distribution of the true treatment allocation arms. On the other hand, there is some sort of signal to this because the baseline ASCVD risk score, and ASCVD risk score is just a composite risk assessment tool that uses a lot of cardiovascular risk factors to give a person's 10-year risk of developing atherosclerotic cardiovascular disease. That's not directly relevant here, but just gives you an information spectrum of that individuals who had similar ASCVD risk score or similar cardiovascular risk did tend to co-localize, that the blues were close to the blues and the oranges were close to the oranges. But that wasn't enough to distinguish the people. There were people who had a similar risk score, but were spread on other parts of the Phenomap, mostly because there were 50 other features that were being considered in constructing a Phenomap of the sort. Now, sort of like switching gears to the results of the major sports results of the trial, and I will kind of delve deep into each component of these assessments. But this was the Phenomap of the MACE outcome. So for each person in their 5% phenotypic neighborhood, as I mentioned, we assessed their individual hazard. And as you see, there is a diversity of hazards across the Phenomap. And the blues of the spectrum favor functional testing. The red end of the spectrum favors anatomical testing. And the key aspect I want to point out, and that is each dot, of course, I want to mention that is as an individual in the trial. And then all through the trial, you see a variation in who would benefit from anatomical or functional testing. And if we plot these hazards, just a continuous density plot of what I showed in the Phenomap, you see that they are distributed around the central effect estimate, which was null, both for the major adverse cardiovascular events outcome, the primary outcome of the trial, and the death and MI outcome, which was used in other studies that we kind of will go through. And so there isn't that, so one of the discussion points always, is this just, variation around the mean, which we would definitely see that if you take a small subset of a large population, you'll have random noise, but they'll be distributed around the mean. So we did take that in account, but then we had to take a sort of next step to figure out if we can get some useful information from this data. But before we sort of jump into that, there's always a question of what neighborhood size to use. In this particular analysis, this was our first pass, the first major publication. we had to choose one to define a primary population. But we did have a more distance agnostic measure where we first assessed what happens if you go from a neighborhood size of 2.5% of the trial to 15% of the trial. So if you go from a smaller trial to a larger trial, so neighborhood size, you have, and the thing that I'm assessing here is the degree of how red they are and degree of how blue they are. You see there are extreme colors here. The darker blues and the darker oranges are more prominent in the smaller trials, suggesting that there are more extreme effect estimates in a smaller neighborhood size. But as you go to larger neighborhood sizes, the more pastel or the middle colors become more prominent, suggesting that you have more effect estimates closer to the mean, which this would suggest that take a larger effect estimate because you would be able to get a more stable estimate if you take a larger neighborhood size. The challenge, though, is that as you go from a smaller neighborhood to a larger neighborhood, you lose a lot of the homogeneity of the neighborhood. So the key aspect of the analysis was the fact that people around an individual resemble that individual. So if we created this metric called the neighborhood affinity metric, assessing how homogeneous was the neighborhood, and the homogeneity of the neighborhood reduces substantially as you go from the 2.5% neighborhood to the 15% neighborhood, such that if you see a red predominance here, suggests that for the most part, most neighborhoods had people that resembled each other, and it actually becomes less and less prominent as the neighborhood size becomes big. So, and to better understand that, we actually did conduct an assessment where we constructed a Monte Carlo simulation where we allowed the neighborhood size to randomly vary between 2.5 to 10%, and compared it to our primary analysis of 5% neighborhood size. And the log hazard of neighborhood effect estimate was fairly consistent with very high degree of correlation and without any bias. Does that help sort of like our discussion? I know I wanted to bring back and pause for a second.
Okay. I'm interested in better understanding the statistical significance as you change the neighborhood size, right? For a very small neighborhood size, you might just by chance observe differences between these. That would correspond to a hazard ratio that's bounded away from 1.
And I think that's definitely true, and that's why when we sort of go to the next phase of building a tool for assessing individual effect estimates, we try and move away from the phenomap itself, but to build out generalizable features that consistently predicted benefit in one arm versus the other. And I'll sort of delve into that next. And so how to use the phenomaps sort of just for understanding, if we have 159-year-old woman presenting with diabetes, hypertension, who's never smoked before, does not have dyslipidemia, and presents with atypical chest pain, you would imagine that this person would end up falling in a single type of cluster, and people who resemble this person would be one kind of person. But we found, and this is a representative example chosen specifically to highlight the differences that emerged like this, is that the first person who resembled this on the phenomap was much more likely to have better outcomes if they underwent functional testing. A second person in the phenomap who resembled everybody on all these 5 characteristics, there was no significant difference between anatomical and functional testing. A third person in the phenomap who actually resembled these characteristics did much better with anatomical testing. And the only reason I sort of bring this up too is the fact that individuals have so many other characteristics that define their features. So using their BMI, their actual blood pressure, if they're taking a rate control medication, if they're currently on an antiplatelet agent, and a slew of other features that we don't consider even if we are considering a similar looking person. So similar looking person for subgroup analysis may be very dissimilar throughout. And that's sort of the only sort of takeaway from this. But then how, I think the key question that was just raised, how do we translate phenomapping?
Yeah, one question I have, Rohan, which is, so did these effect size seem really high, like hazard ratio of 4 or 0.25? And I guess my question is, were those like extreme outliers? Like it kind of seems like beyond the point of plausibility.
So I think one of these, as you can imagine, the CIs for any of these phenomaps would, if they have to be significant, they have to be large effects. Just because you have to, so the trial was powered to detect something. So if you're detecting something in addition to the trial, these have to be the extreme cases within the trial, and not extreme in the sense that these are isolated cases that have just extreme effects, but those who have the larger effects are the individuals who are more likely as a group to be driving the benefit from CT versus anatomical testing. And one specific thing I would want to highlight, that this example was mostly chosen based on, we specifically chose this example to say that there is diversity. This is not our tool. This is not the application of the algorithm at all. So some of the high effect sizes was the fact that we were looking for individuals. We chose an example with 5 features, but we found 3 individuals who resembled this person. I mean, it was, I don't know if I'm sort of able to answer that question as well. But the idea is that they may seem implausible, but the actual effect estimate is sort of not the key aspect. The key aspect is that somebody was substantially better than one arm was substantially better than the other.
And then did you try, if that makes sense, did you try like some like very reduced model? Like so a lot of clinicians will be like, okay, if someone's very overweight, they do like a CT because the other test, it doesn't do it. And so it sounds like you're going to get into that a little bit. How would this compare to like some heuristic that random clinicians may or may not have?
Yeah. So I think I sort of like will go through like some generalizable features, because it's not possible to like either use any tool that's built on 56 features, because how are we going to capture those features? The incremental cost of getting those features is so high. Plus that would introduce random errors, because you are trying to define a person very specifically, and that specific feature set may actually may identify individuals who were different by chance alone, who had an effect by chance alone. So we wanted to identify features that consistently benefited either anatomical testing or functional testing, and using these neighborhood-specific hazard ratios as our outcome of interest and patients' features as the exposures. We looked at things that may actually help identify more generalizable features that consistently predicted benefit from anatomical or functional testing. So for this, we use extreme gradient descent boosting, which is just a collection of trees, and with the goal of identifying, again, the features that are more consistently associated. We use Shapley values that a higher value numerically is associated with a stronger switch in the model outcome. So essentially, if on the plot on the right says, if you had a higher value Shap value for or a higher value of a particular variable, and their particular Shap value would determine how much the effect estimate changes. So the things that are on the top are the ones that have the strongest effect on determining if patient undergoes anatomical or functional testing. And this is unidirectional. And this sort of plot on the right gives you a bidirectional sense that for, say, hypertension, which is a yes or no question, a purple, which is presence of yes, would actually favor anatomical imaging. And a no would strongly favor functional imaging. And the no would actually have a much stronger influence than the yes. And this sort of like plays out in each outcome, and both the binary outcomes as we have the categorical risk factors, as well as HDL, body mass index, total cholesterol, and age, which are continuous features, but a higher value would predict one direction versus the other.
So, sorry, can I just ask a question? I must have missed this earlier, but when you're assigning the phenomap, how did you handle binary versus continuous? Did you introduce the noise?
Gower systems. We one-hot encoded all the categorical features, and for continuous, we turned them into z-scores. Because Gower's metric is designed to construct dissimilarity matrices across both numeric and non-numeric data, I think we were just well-suited. That was a well-suited dissimilarity metric that we used.
Okay, thanks.
And then, I think
I can ask a quick question here as well. So you said the outcome that you're predicting here is actually the predicted hazard rate ratios. Is that right from your?
Yes.
So how does that compare? And maybe this is the wrong question, or I'm not thinking about this correctly, but how does that compare to the actual? Like, instead of if you're looking at that, but I guess if it's hypertension and that's a binary variable, then if you actually did that not on the on the model predicted hazard rate ratio, but the actual hazard rate ratio of the cohort.
one of the things I would sort of have to point out, there is no gold standard, right? There is no true for a person with hypertension or a person's true hazard ratio. Every single hazard ratio that you can test currently, I mean, I think that's the bigger challenge, right? That's the thing we're trying to solve. What is the hazard ratio for a person with some features within a trial? Or what is the, leave aside, what is the hazard ratio for an individual person in a trial? And we just don't know the true effect. And this, our model derived effect is the surrogate for the true effect, is what we are positing. Again, we may agree or disagree with that, but that is the sort of, sort of heuristic here.
Gotcha. Okay, thanks.
Is it fair to say that the model basically predicts what would happen if you had functional imaging, and it predicts what would happen if you had anatomic imaging?
Yeah.
And then the ratio between those two is the hazard ratio. So obviously what you always want to observe in epidemiology is like the factual, which is like what happened, and the counterfactual, which is like what would have happened had you made a different choice. And so I think this is basically saying it's a model that predicts both of the outcomes. And then to a first approximation, you could just divide the two, and that would be like a hazard ratio. Is that it?
Yeah,
Is that oversimplified but accurate?
No, I think that's accurate. I mean, if people were followed for the same amount of time, the division would work perfectly every time. It's just because these are time-driven outcomes, we had to use Cox, so that just adds a layer of complexity to it. But I think that's a good theoretical framework for sure. And again, I mean, happy to answer further questions too. But the next slide does answer one of the questions that had asked earlier, is that how does, having a hazard, what did having a specific hazard within the population, what does it imply for what test actually people underwent? So within the trials context itself, a particular hazard did not determine anatomical function testing, which I think, I don't want to overinterpret it. And this is the training set. So we for the XG boost I did not mention, we didn't use the entire Phenomap. We used only 80% of the selected population to direct the tool. So we had a test set to test the model. And we used those XGBoost based features to create a second XGBoost model that now is predicting, it's a parsimonious model for the log hazard. So essentially the log hazard is now predicting by the fewest features available. Instead of predicting favors anatomical, favors functional, we are predicting the absolute log hazard of sorts for that individual based on the set of features that we have here. So these features were put into a second model, the XGBoost. This is the basis of the tool that we finally did propose in the study, which actually is an individualized hazard ratio, not based on a trial, but based on their features. And the trial itself doesn't have any difference. So if you were more likely to benefit from anatomical testing or functional testing, you didn't undergo a different test because of that in the trial setting. And that's something we're testing in the real world setting currently, is how does a cis-recommended test correlate with what we do clinically, which is your question specifically. And this is true for both the training and the test set, that the anatomical supporting by assist doesn't mean that people underwent anatomical testing. But that did allow us to do something important, was to see discordance. So if somebody was recommended assist, so assist recommended anatomical testing, or assist recommended functional testing, and they actually underwent the anatomical testing, which is the purple line, or the functional testing, which is the red line, versus the green and the teal lines, those who had the test that was recommended, concordance with the assist tool per se, they had a much better likelihood of event-free survival, or survival that was free of adverse cardiovascular events. But those who had a discordant test were more likely to have adverse outcomes. And I think this is where effect estimates are probably more interesting, is that you have 5% difference even in the extreme groups, which are like more realistic estimates across estimates, rather than the large single effect around the person. Nevertheless, these we tested, this is the training set, so we expected this to somewhat replicate what was seen. But even in the test set, we found that, and the lines actually overlap here, so they're hard to see. But those who had assist recommended anatomical testing or assist recommended functional testing, they had much better outcomes than those who had discordant tests. And in assessing in comparing groups, so what I have here are people in the purple here who had the assist recommended anatomical test. They had an anatomical test divided by assist recommended anatomical test for the end of functional test, which is what we have here, which we have here versus the other group, which is what was recommended versus what was done. And there is a significant interaction by the test they underwent versus the test they were recommended. And this essentially is a replication of the plot on the left to the right. So how does, one of the key questions that always happens is you took a trial population, just use the data to create a phenomap, you create a tool inside the phenomap, you tested it in the population. What is the value to clinical care? Because, it's hard to know if it actually is just an overfit model doing really well in that population. So for this, I think that's where Scott-Hart came in. So I remind people again that Scott-Hart did not test anatomical or functional testing as a strategy. It tested anatomical testing as an add-on to standard of care. But the benefit of such a loose sort of population is that there were individuals who actually hadn't undergone any stress testing before versus individual who had actually undergone functional testing before. And so this is no longer a randomized clinical trial because we can only focus on the people who didn't have a stress test before their anatomical testing and those who had a stress test before. But nevertheless, was a population where at least the treatment, the allocation of the diagnostic test wasn't biased with clinical care. And then the outcome that was studied in this population was death due to coronary heart disease and non-fatal MI, which was a rarer outcome, but we still used the primary outcome because we felt that was the most robustly obtained outcome in the trial. So this is the same sort of plot, but now we're using the Scott-Hart population. This is the external validation of assist, where again, the purple and the red represent concordant strategies and the green and the teal represent discordant strategies. And in the external validation cohort, which is unmatched, which is 300 people with CT compared to 1,800 people who underwent stress tests, you see a large concord effect similar to what we were seeing in the PROMISE trial. If you created a matched subset, which is you created a propensity score matched cohort of CT tested individuals to those who resembled the non-CT test or the functional test people, we similarly had a similar effect where those concordant had better outcomes than those discordant. And this bore out in interaction testing too. And we did modify the outcomes to see if we use a consistent outcome instead of the primary outcome, so that you could actually generalize from one trial to the other. We did find very consistent effects on a different outcome of all-cause mortality and non-fatal MI, which was consistently obtained and defined across the two trials. So I think Assist now is available as a clinical decision support tool. Again, this is still a research tool. You can access that on our lab website, but we are prospectively validating this tool, both in what clinicians do in response to this, the quality of care that it actually implies, and third, if there is a prospective validation in terms of the randomized clinical trials to define people if on their treatment strategy based on Assist, which is also something of a works in progress for us. So in summary, just based on what I discussed, that there is heterogeneity in outcomes with testing strategy in the null PROMISE trial, which was theoretically seen, but also now seen empirically. A series of local experiments in a high-dimensional phenotypic representation can uncover this heterogeneity to a certain extent. And then our tool is practical that it individualizes the choice of anatomical versus functional testing, identifying people who would benefit more from one testing or the other, condition on hard outcomes. But the limitations are we don't have great mechanistic explanations as we discussed before, and that is it better if a person who is recommended Assist CT testing by Assist undergoes CT scan, do they have a better quality study? Do they identify subclinical disease which gets them a statin agent or some other therapy? That's actually just something that we're actually actively exploring. And then this is a post-hoc descriptive analysis. This is not prescriptive at all. And then validation from Scott-Hart was selected subset, was not a randomized clinical trial. And as I said, we are trying to do broader implications of the approach. And while I presented just this tool because that's the one that is currently available in published literature, we have several under peer review that focus on this application to therapeutic strategies, to positive trials, to null trials, to safety outcomes, and so forth. So, I hope we can sort of have that as a future conversation. And I specifically want to acknowledge the first author of the study, who is a resident now, a rising fellow program, a superstar in our program, and then a key sleuth of investigators across both the US and internationally who helped us sort of accomplish the goals here. Thank you.